All righty, great. Good morning, everyone. Good morning, Dr. Lee.
Good
Welcome.
morning.
Glad you're here. Thank you very much. I see a lot of your pulmonary colleagues online right now. Nice to see. Hi, Saxy. And I'll turn it over to Jim and he'll introduce us and get us started.
All right, good morning, everyone. Welcome to this installment of our virtual Grand Round series. This morning, we're very fortunate to have Dr. Alison Lee speaking for us. Dr. Lee earned her medical degree from the University of Massachusetts and then went on to complete residency in internal medicine at NYU, followed by fellowship in pulmonary and critical care medicine at Columbia before joining the faculty at Mount Sinai. She currently serves as an assistant professor in the Division of Pulmonary, Critical Care, and Sleep Medicine and conducts research examining the influences of environmental and socioeconomic risk factors in the development of chronic disease, with particular focus on environmental influences in the prenatal and early childhood period and their contributions to development of chronic diseases later in life. Please welcome Dr. Alison Lee.
Thank you very much. Can everyone see my slides? Great, perfect. Okay. So thank you very much for the introduction and the kind invitation to speak today. I'll be speaking with you about the work that I do in Ghana, specifically looking at an exposure that you may not have heard of, which is household air pollution. I have no disclosures. So just an overview of where we'll be going today. First, starting out by talking about poverty and health, just offering you a framework of how I approach the problem. And from there, trying to relay the importance of early life on the development of chronic disease. So specifically looking at what's known as the DOHAD theory, or the developmental origins of health and disease, but then really focusing on lung development and why early life may be so important. From there, we'll talk about household air pollution, which I believe is a globally important environmental exposure, and then moving into work that we're doing with the Ghana randomized air pollution health study. So it's well described that zip code determines how long you live. This is data showing that these are counties in California. And essentially what you can see here is that in the wealthiest counties, such as Marin County, average life expectancy is over 83 years. Whereas in the more impoverished communities, average life expectancy is, let's say, 76 years. And again, this is really just crude data, but demonstrating this strong relationship between poverty here by household income and life expectancy. And of course, if we look worldwide, this is magnified even further. Here you can see that throughout sub-Saharan Africa, life expectancy is essentially below 65 years of life. In Ghana, where we work, which is outlined here in red, life expectancy is 63 years. So this is compared to an average of 78 years in the United States. And clearly this is not due to genetic differences. Clearly there are changes in the environment that are a result of poverty and economic inequality that work together to produce health disparities. And these are really the so-called social determinants of health. This is by no means an exhaustive list, but I think we can understand that environment such as built environment, access to healthcare, healthy foods, education, environmental pollution, poor housing, stress, and income all work together to produce health disparities. And it's really important to understand that these health disparities begin to act in early life. And so in the 1980s, Barker and his colleagues were trying to understand differences in mortality rates from chronic disease. And they noticed that these, while there were reductions in mortality rates across England and Wales, the reductions appeared to depend on socioeconomic status of those communities. And they hypothesized perhaps that the reason for this was differences in health in early life. And so what they did is they decided to try to understand whether or not there was a relationship between mortality in adulthood and infant mortality at the time when those adults would have been infants. And so they looked at a number of different diseases. Here's looking at ischemic heart disease and essentially looking at the correlation between ischemic heart disease and neonatal mortality by community. And you can see that there's a strong relationship that they noticed. And further, when they broke this down by socioeconomic status, SES1 being sort of the wealthiest communities and SES5 being the most impoverished, you can see that there are stark differences both in infant mortality and also mortality of chronic diseases in adulthood. Here just showing chronic bronchitis and emphysema with our standardized mortality rate of 36 versus 188. And this is just that same data described graphically, where you can see here the X's are the most impoverished communities. These communities down here are the wealthiest. And so again, just a strong relationship demonstrated here between ischemic heart disease on the left, bronchitis on the right, and neonatal mortality. They went on to see whether or not they could identify sex-specific effects, and indeed they did. They found that the relationship appeared stronger in women as compared to men. And so from this data, they concluded that adverse influences in childhood associated with poor living standards increase susceptibility to other influences associated with affluence encountered in later life. They did wonder, though, could we look at markers in earlier life? So they looked at blood pressure in children at age 10 and adults at age 36. Just for brevity, I'm only showing you the data from 36, but this is the same in children. And essentially what they did is they wanted to examine whether birth weight as a marker of the intrauterine environment would be associated with blood pressure at these different ages. And what they found is that for men, both men and women, those men and women with the lowest birth weight also had the highest systolic blood pressure. And this was true even when they stratified by current weight. And so I think that these two studies together really start to bring out 4 important points. One is that vulnerability to disease across the life course begin in utero. And the work that I do is trying to understand how exposure to adverse environments could be important in that. We also start to see that there are parallels across organ systems, suggesting perhaps an interrelatedness of organ systems and perhaps an interrelatedness of underlying mechanisms. We see, especially with the blood pressure work, that there is tracking of development across the life course. And we also start to see a suggestion of sex-specific effects. So now narrowing more into lung health. Hopefully I can explain to you why, as an adult pulmonologist, I'm most interested in studying early childhood. So even before Barker's DOHAD theory, this is work by Fletcher and Peto, and this is sort of the seminal work demonstrating FEV1 trajectories. And what they did is they recruited over 1,100 working men from central London, and they followed them with lung function measurements every 6 months. And they used those repeated measures to construct FEV1 trajectories. They made the assumption that everyone reached 100% maximally attainable lung function. And then they noted that everyone, even healthy non-smokers, had a decline in lung function after this time. They also noted that those persons who were smokers and susceptible would have a rapid rate of lung function decline. However, if you stopped smoking, your lung function would never return to normal, but the rate of subsequent decline would begin to approximate that of never smokers. And this really was the paradigm of COPD until a number of decades later, when Lang et al. Published this seminal paper in the New England Journal, where they leveraged 3 cohort studies, the Framingham Offspring cohort, Copenhagen City Heart Study, and the Lovelace Smokers cohort, that had longitudinal follow-up of its participants for more than 20 years with repeated lung function measurements. And using this data, they categorized people into having normal or low FEV1 at baseline, and having COPD or no COPD at study end. And so essentially they created 4 groups: persons who had normal or low FEV1 at inception and no COPD at study end, versus those who had normal or low FEV1 at inception with COPD at study end. And what they found is that of the 500 people who would go on to develop COPD, a significant proportion, here 62%, of those people actually had reduced maximally attainable lung function. And what's more is they discovered that the rate of lung function decline in those persons was actually normal, as compared to those people who had a normal maximally attainable lung function. They, as would have been predicted, would have a rapid rate of lung function decline. And this was true whether they looked at cc's per year or z-scores. And so really this starts to bring into question the prior paradigm of COPD, whereas before we thought that the path to COPD was from 100% maximally attainable lung function with a rapid decline in lung function. In fact, now we understand that reduced maximally attainable lung function is a major risk factor for the development of COPD, even with subsequent normal rates of lung function decline. And so that sort of brings into question, well, what is this low lung function phenotype? Is this just the tail of a normal distribution, or could this be a distinct phenotype? And if it is, when is that early trajectory set, and what factors contribute? And to understand the answer to that question, we have to look at longitudinal cohort studies. This is one of the longest ones, or sorry, the largest ones, with over 2,400 participants. And in this study, they recruited participants at age 7 and followed them with repeat spirometry through age 53. And if we look at these lung function trajectories that were constructed, what you can see is that by age 53, there's 3 different phenotypes that have low lung function. This would be a below average group, a early below average with an accelerated decline, and a persistently low group. They then went on to look at associations between these phenotypes and risk for COPD. And what they found is that those persons who had below average lung function trajectory had almost 4 times the odds for developing COPD. Those who had persistently low had 9 times the odds, and those who had early below average accelerated decline had 35 times the odds of developing COPD. What's more, when they looked at these 3 phenotypes together, they found that these 3 phenotypes made up over 75% of all COPD cases at 53 years and 100% of the moderate to severe COPD cases. But I think if we examine these trajectories closely, what you'll notice is that they appear to be distinct even at 7 years of age. So perhaps we need to look even earlier. And for this, there's not many studies, but this is one, a smaller study from the Tucson Children's Respiratory Study, where they measured lung function in infancy at 1 to 2 months of age and followed the cohort for more than 20 years. And what they found is that those infants who had the lowest quartile of lung function had persistently reduced lung function, even after 20 years of follow-up. And this was true regardless of the spirometric measure that they looked at. And so then these data taken together sort of allow us now to focus in on this early life period, perhaps even extending to the prenatal period, to try to understand or examine different factors that may contribute to lung health. So we can think of genetics, but obviously also think of environmental pollutants, both chemical and non-chemical in nature. And of course, I've spoken mainly about lung health, but I think we can see parallels if we look at cardiovascular development and growth. And we know from other research as well that there is an interrelatedness of organ system health. For example, we know that growth influences cardiovascular health and lung health influences cardiovascular health and endocrine and metabolic, and is also associated with mortality. So clearly, as described by Barker, we do see interrelatedness of different organs. So moving from here, hopefully I can now introduce household air pollution and hopefully get you to understand that this really is a globally important environmental exposure that plays a significant role in childhood health. So what is household air pollution? Well, 40% of households worldwide are reliant on the burning of solid fuels for their daily cooking and heating needs. And this is disproportionately so in sub-Saharan Africa, where more than 3/4 of households are reliant on these fuels. And partly due to sort of just the widespread use of these fuels, there's substantial morbidity and mortality on the order of 2.8 million deaths every year and 85.6 million dailies or disability adjusted life years. These are examples of 2 traditional cook stoves. This is a charcoal stove, and this is what's called a 3-stone fire, essentially just 3 piles of mud that are in close proximity so that the pot can sit on top, and then the solid fuel is pushed underneath. And these are combustion inefficient cook stoves, which essentially just means that they produce a lot of smoke, they produce a lot of toxicants at very high levels. And we know that these exposures are occurring over the life course and therefore are associated with morbidity and mortality, both in childhood and adulthood. These are some examples of solid fuels that are burned. So especially in agricultural communities, following the harvest, you'll see crop residuals being burned. Charcoal, as I mentioned to you before, particularly in areas that are near forests, you'll see wood being burned. Areas at higher elevation or areas that have a lot of livestock will also burn animal dung as well, which can be quite toxic. And if we think that tobacco, which essentially is a biomass, produces a number of different health outcomes. Biomass smoke essentially has the same constituents with the exception of nicotine. And so really any health outcome that you can think of that would be associated with tobacco smoke, there really is beginning to be evidence that we can see the same health outcomes with household air pollution. I will say most of this work is cross-sectional in nature or leveraging questionnaires, and therefore there really is a large literature gap, data gap that needs to urgently be filled, particularly looking at exposure-response relationships. And of course, when we think about household air pollution, the behavioral context is important. So we know that women are the primary cooks. They continue to cook while pregnant. And therefore, we conceptualize that exposure to household air pollution really does begin in utero. We also know that children frequently will stay, especially young children, will stay by their mother's side. And therefore, they also have high exposures. But that's not to say that others are not exposed. If you've ever been to one of these communities during cooking times, what you'll notice is that essentially there is a layer of fog, or a layer of smoke, excuse me, that it just lays over the entire community. And so really there is no one in the community that is unexposed. And so what sort of exposure levels are we talking about? So this is data that was published almost 10 years ago now, using satellite-based models to try to understand exposures in New England. So this is sort of equivalent to what you or I may be breathing on a daily basis. And just to point out here that the range is on the order of 6 to, let's say, 12 micrograms per meter cubed. So keeping that in mind, what sorts of exposures are we talking about with household air pollution? So we don't, with our studies, we don't have the luxury of using satellite-based models. And so our participants all wear personal exposure monitors. And that means with our exposure data, we're able to get real-time measures of their exposure. So that's what you're looking at here. So on the x-axis is a time series starting at 1:06 and running through 1:09 at a little bit before 11 o'clock in the morning. And here on the y-axis is the exposure concentration. And I just want to point you out to the scale here. So we're talking in the thousands of micrograms per meter cubed. So already just an exponentially higher exposure as compared to what you or I see every day. And you can see that these sort of peaks, these are cooking periods. And during the cooking periods, the exposures are routinely going up into the thousands, with some spikes, reaching 6,000 or even exceeding 6,000. And in this particular example, the median exposure over the 3-day period was 125 micrograms per meter cubed. This is another example where, again, you can just see these clusters of exposures, again, reaching into the thousands. And again, here, the median exposure is 151.7. We also measured carbon monoxide as another product of combustion. So same graph here, where on the x-axis is a running time series. On the y-axis is our carbon monoxide in parts per million. And you can see that there's just these huge spikes in carbon monoxide exposure that correlate with cooking periods and are well in excess of the EPA guidelines. The degree of exposure is incredibly important, especially when we think about interventions that could be used to reduce exposure. So here's the exposure response curve, and you can see this is for pneumonia, and you can see that the exposure response curve is incredibly steep at lower exposures, but then it begins to plateau as you move into higher exposures. So you can imagine that if you have an intervention that, let's say, has a 50% reduction in exposure, you may still be operating on the flat portion of the curve. And really the question is, how do we introduce an exposure that's able to move you into the steep portion of the curve and move you below what currently is a WHO interim target for indoor air, which would be below 35 micrograms per meter cubed. And so this is what we've been attempting to do and study in our work in Ghana with the Ghana Randomized Air Pollution and Health Study. So in 2013, we recruited over 1,400 pregnant women from Kintampo, Ghana. And again, Ghana is in West Africa and Kintampo is located in the Middle Belt. And we randomized these pregnant women to receive one of two cook stove interventions. The first being a gas stove or LPG stove, which is similar to what you or I may cook on at home. The second being an improved biomass stove or BioLite, which allows the women to continue to burn solid fuels, but has improved combustion efficiency properties, or control, which is a 3-stone fire. The inclusion criteria were that the women had to be less than 24 weeks gestation with a singleton fetus. They had to be all non-smokers, and they had to be the head cook of a household. In addition, we performed repeated personal exposure assessments. This is both of the pregnant woman and then over the child's first year of life, both of the child and the mother. And we measured carbon monoxide and PM 2.5. And we performed this 4 times prenatally and then 3 times over the first year of life. And the main outcomes for the study were birth weight and acute lower respiratory infection or pneumonia in the first year of life. But as I'll talk about, we also measured child anthropometrics every 3 months. And current funding is allowing us to follow this cohort through child age 7 years. So these are the stoves again. So this is the 3-stone fire, the traditional cook stove. This is the BioLite stove, so the improved biomass stove, and this is the LPG. And it's just important to note that for the study, we provided support for the stove. So we fixed any issues that may have arisen. And also, particularly for the LPG arm, we provided an unlimited supply of fuel so that the cost of the LPG gas itself would not be a limitation to adherence to the stove. Birth outcomes were measured within the first 24 hours of life, and this was regardless of whether the births occurred at home or in the clinic. Our pneumonia surveillance or acute lower respiratory infection surveillance involved field workers who visited each house every week and followed the WHO integrated management of childhood illness. So essentially what this does is it looks for children that are having difficulty breathing. It looks at their respiratory rate and other symptoms, and essentially categorizes them into having pneumonia or severe pneumonia. We then took any child who was sick or unwell and referred them for physician evaluation. And again, we provided support. So we provided transportation. All households had insurance through our study. And then the physician evaluation was paid for by the study as well. So we did everything we could to try to promote getting children who were identified by the field worker as sick to the clinician for a visit. And our primary outcome was physician diagnosed pneumonia or severe pneumonia in the first year of life. So this is the study flow where, again, we randomized 1,400 women. They were assigned to our 3 study arms. These pregnant women, resulted in 1,310 live births. And you can see here those children that, unfortunately did not make it through the first year of follow-up, but resulted in approximately 55,000 child weeks of field worker follow-up. So what do we see with our intention to treat? Well, unfortunately, with the intention to treat analyses, we did not see a statistical reduction in birth weight, which was our main birth outcome between arms as compared to control. When we looked at our pneumonia outcome, we similarly did not see a reduction in either physician-diagnosed pneumonia or physician-diagnosed severe pneumonia. I think this is probably one of those cases where you would look and you would say, is that 1 line or 3? In the blown up version here, we do see a little bit of separation, but that was not statistically significant. And so why might that have been? Well, our hypothesis is that although our LPG arm did have a significant reduction in exposure, unfortunately, we still did have a lot of overlap in exposure between these arms. And further, when we look at the average exposure in the LPG arm, we see that we did not reach that WHO threshold of 35 micrograms per meter cubed. So perhaps a combination of our exposures were still too high, and we had too much overlap between study arms. So what about exposure response analyses? So as I said, we measured exposure at 7 time points, 4 prenatally and 3 over the children's first year of life. These are exposure response analyses looking at the relationship between prenatal and postnatal household air pollution and pneumonia. So this includes infants who completed 1 year of follow-up. And you can see we have almost 55,000 child weeks of field worker follow-up. In total, we had 392 episodes of physician-diagnosed pneumonia and 123 episodes of physician-diagnosed severe pneumonia in our cohort. And when we look at the relationship between prenatal and postnatal household air pollution exposure on pneumonia and severe pneumonia, what we see is that it appears that prenatal exposure is associated with an increased risk for the development of pneumonia and severe pneumonia in the first year of life. And when we look at sex stratified analyses, it appears that female infants may be more vulnerable to these effects. And again, these results are all per 1 ppm increase in carbon monoxide. So these are exposure response analyses. We then wondered, well, if we see this effect of prenatal exposure on pneumonia, could we identify a sensitive window of exposure? And so when we look at our exposure protocol, what we see is that the exposures were based on gestational age at enrollment. So we had one assessment done prior to the intervention, and then 3 spaced equally between intervention and birth. So these exposure assessments were not done based on gestational age, but rather based on when the women were recruited. And this is just a histogram showing you sort of the spread of when we performed exposure measurements in the cohort. So here the y-axis is the count, so the number of exposures that we had taken at each week gestation. So you can see we have pretty good coverage starting at 7 weeks gestation. And so we can use this data in a distributive lag model framework to try to understand the time varying association between increased prenatal household air pollution exposure as indexed by carbon monoxide and odds for developing severe pneumonia or pneumonia in the first year of life. So here on the x-axis, we have gestational age in weeks. The y-axis, we have the odds ratio for developing severe pneumonia. And what you can see here is that when our odds ratio and confidence interval, and in the bracket here is a Bonferroni corrected odds ratio, or sorry, confidence interval. What you can see is that we identify a sensitive window where those confidence intervals do not include 1, suggesting perhaps that increased exposure in late gestation is associated with increased risk for pneumonia. And we can see a similar thing, it's hard to see, but this is statistically significant, where we see that in late gestation, there appears to be an association between increased exposure to CO and this is physician diagnosed pneumonia. And again, these are per 1 ppm increase, or sorry, this is per 1 unit log increase in prenatal CO exposure. So I think we can now add to our results and say, although we didn't see an ITT effect, we do see that increased prenatal household air pollution exposure is associated with increased risk for pneumonia in the first year of life, and that girls may be more vulnerable. We also, within a subset of our cohort, performed infant lung function at 1 month of age. This was only in 400 mother-infant pairs. And of course, you can't perform spirometry in infants, so we did tidal breathing analyses, where essentially you can get an expiratory flow parameter, which is the time to peak tidal expiratory flow to expiratory time. You can also understand tidal volume, respiratory rate, and minute ventilation. And what we found is that there was an exposure response association, essentially that increased prenatal exposure was associated with impairment in expiratory flow and an increase in respiratory rate and minute ventilation. And again, these are per 1 ppm increase in average prenatal CO exposure. And again, when we looked at sex stratified analyses, we see that girls appear to be more vulnerable to these effects. We then wondered, could these changes in respiratory mechanics influence risk for future pneumonia? And in fact, when we looked, we did see a very small but statistically significant increase in the odds of developing pneumonia. Again, here's per 1 unit increase in respiratory rate. So we can now add to these findings and say that increased prenatal household air pollution exposure may also be associated with impaired infant lung function that's measurable at 30 days of life. And again, we see that girls may be more vulnerable to these effects. As I mentioned, we measured anthropometrics in the children every 3 months. So over the first year of life, we have 5 potential measurements at 0, 3, 6, 9, and 12 months of age. I will say that data completeness for these measurements was very high. So over 76% of the cohort had all time points measured. And an additional 14% had these anthropometrics measured at 4 time points. In these analyses, we did start to see a suggestion that perhaps our LPG arm had effects outside of exposure reduction. So here we see that those women randomized to the LPG arm were essentially all continuing to breastfeed their children at 12 months of age. Whereas in the other 2 arms, that number was closer to around 80%. So we leveraged these repeated anthropometrics to develop trajectories of growth. And what you see here are the trajectories that we identified for weight, length, head circumference, and mid-upper arm circumference. And I think just an important observation is that we see that these trajectories appear to be distinct at birth, although you do note some changes in slope in the first 6 months of life. We also used WHO Z-scores to calculate height for age Z-score, weight for age Z-score, and weight for height Z-score. And I think the important observation here is really that the cohort is rather a frail cohort. So in the United States and in other developed countries, for example, you would expect to see that children are overweight and have, for example, Z-scores greater than 2. Here we see just an overall shift of Z-scores down, so that we have a group for each Z-score that is just persistently below -2. So for example, 10% of our population is stunted, and another 44% of our population is just persistently at risk for being stunted. And the same is true if we look at underweight and being at risk for underweight, and wasted and at risk for wasting. So again, just a very, what I would characterize as overall, just a very frail cohort. So we then used ordinal logistic regression to try to understand whether prenatal and postnatal household air pollution exposure were associated with these trajectories. And what we found is that increased prenatal household air pollution exposure increased risk for lower or smaller height for age Z-score, and perhaps the factor with the most public health significance is stunting, such that a 1 ppm increase in prenatal household air pollution exposure, as indexed by carbon monoxide, was associated with an odds ratio of 1.25. When we looked at postnatal household air pollution exposure, we saw that increased exposure was associated with increased risk for lower or smaller head circumference, mid-upper arm circumference, and weight for height Z-score or wasting. And again, here the CO is on 1 ppm increase, and the PM 2.5 is per 10 microgram per meter cubed increase. We again looked at sex-specific effects, and here the results appear to vary based on pollutants. So girls appeared more vulnerable to the effects of PM 2.5, and boys appeared more vulnerable to the effects of CO. We then asked, well, if we see an exposure-response relationship, might our cook stove intervention be able to ameliorate some of these effects? And here you can see that we don't see any significant findings for the BioLite arm, but in the LPG arm, we do see that those infants born to mothers randomized to the LPG arm have reduced odds for the development of smaller head circumference and smaller mid-upper arm circumference as compared to control. And so we can now add to these findings to say that prenatal and postnatal household air pollution exposure effectively impair nearly all metrics of growth and increase risk for stunting. And perhaps we're starting to see that the LPG cook stove can ameliorate some of these effects. So as I mentioned before, we're now funded to follow the cohort through child age 7 to look at lung development. So we have lung phenotyping visits at age 4 and 7, and then we perform repeated personal exposure assessments and also continuous community level and central site monitoring. And so I'll share with you some of the results that we have thus far from our age 4 visit, which has been completed. So for lung function in a 4-year-old, clearly you cannot do spirometry, or at least you cannot do it well, I would say. So we are employing impulse oscillometry, which is an effort-independent measure that just requires tidal breathing to assess lung function at child age 4. And so here we're using generalized estimating equations to estimate the associations between prenatal and postnatal household air pollution exposures and lung function as measured by impulse oscillometry. And what we see is that if we look at all exposures together, increased prenatal and postnatal household air pollution exposure is associated with an increase in airway resistance, specifically at R5 hertz, 20 hertz, and then the area of reactance. If we look at prenatal and postnatal, what we see is that the effect, while present in both, perhaps may be stronger in the prenatal period. So again, suggesting an increase in airway resistance measurable at age 4 years. So we can add to these findings by now saying that in addition, early life household air pollution exposure appears to impair lung function, measurable not only at birth, but also measurable at age 4 years. We then looked at whether poor childhood growth, which again, we previously demonstrated was associated with household air pollution exposure, is associated with lung function at age 4. So we started out by trying to understand whether birth anthropometrics may be associated with lung function. And again, we see the same pattern. We see that those children who have smaller or lower birth weight have higher airway resistance. We see an inverse relationship. We also looked at measurements at age 4, specifically our Z-scores, so weight for age Z-score and height for age Z-score. And again, we see the same pattern, an inverse association, where those children who have poorer or smaller weight for age Z-score, height for age Z-score have increased airway resistance, both at R5 and R20. And then here for the height for age Z-score, we're starting to see perhaps an effect on the small airways with an increase in airway resistance with reductions in height for age Z-score. We then, similar to how we did before, we created growth trajectories. So using our measurements at every 3 months through 12 months of age, and also extending this to include the measurement at 48 months. And again, we see that our trajectories are distinct and essentially parallel, although maybe you can say that there's a little bit of catch-up growth happening here. But the same pattern is true, where now we have 13% of our cohort that is persistently wasted, and 39% of our cohort that's at risk for wasting. If we look at height for age Z-score, we see that 9% of our cohort is persistently stunted, and 46% of our cohort is at risk for stunting. So still, this clearly just very frail cohort. So if we look at associations between the Z-scores and lung function, so to orient you here, each of these plots is our lung function measurement. So here we have R5, X5, R20, and then the difference, the R5 to 20. And here we're looking within sort of each Z-score trajectory metric. So this is in reference to a normal trajectory, and then we have our normal, low, at risk, and stunted. And what you can see is the same pattern is emerging here as well. So if we see that children who are stunted or at risk for stunting appear to have an increase in R5, and so increase in resistance, airway resistance, as compared to those with a normal height for age Z-score trajectory. And the same is true for R20. Those children who are stunted appear to have increased resistance at 20 Hertz as compared to those children who have a normal height for age Z-score. And if we look at trends, these trends are significant as well. We can now add to this list and say not only impaired growth in the first year of life, at birth, but also at age 4 and also from birth through age 4 appear to be associated with changes in lung function, specifically with this pattern of increased airway resistance. We've started to look, and this is preliminary data that we used for an RO1 application that we'll be resubmitting in November, but we started to look at the association between early life household air pollution exposure and blood pressure. So this is just resting systolic blood pressure, so measured after 10 minutes of rest, measured 3 times and averaged. And what you can see is that we see a dose response effect where increasing early life PM2.5 exposure is associated with an increase in systolic blood pressure to the order of 1.37 millimeters mercury per 10 micrograms per meter cubed increase in PM2.5. What's more, if we try to understand whether or not our cook stove intervention is able to have a lasting effect on blood pressure, we actually see that those infants born to mothers, or those children born to mothers randomized to the LPG arm, appear to have over a 7-point reduction in systolic blood pressure at age 4 years as compared to control. Again, these are just the first 80 or so children, and so we're working on extending these analyses to the entire cohort. And those analyses are underway. And again, we see a similar pattern in the larger cohort. So we're now leveraging that pilot data or preliminary data to think about ways that we can better characterize cardiovascular health in children. And so we're aiming to do this by using ambulatory blood pressure monitoring. So here you can see in a pilot study, we have our children wearing their ambulatory blood pressure monitors. We also have a study where we're doing actigraphy, so trying to understand sleep patterns during and day and wake cycles. This is our air pollution monitor, so our PM2.5 monitor. And then the children are wearing a hexaskin shirt so we can get heart rate variability. So a lot of equipment, but overall this was very well tolerated. And actually the siblings of the children who were wearing this for our pilot study were actually all wanted to wear the equipment as well. And we're sort of jealous that they couldn't do it. So we have high hopes. We have a lot of experience deploying exposure devices in children. So we have high hopes that we can do this successfully in our cohort. And this is just an example of what the data stream looks like. So here's our actigraphy data. It's just where you can sort of beautifully see this is daytime and this is nighttime data. This is our ambulatory blood pressure measurement. So you can see the repeated measures of systolic and diastolic blood pressure just over time. Again, here, the x-axis is time for our measuring period. And then in green here at the bottom, these are our exposure assessments. So again, you can see that there's these spikes in exposure that are occurring at dinner time and also at breakfast time. So I think, the final piece of evidence that we'll say is that perhaps, and again, this is something that we're hoping to explore more, but perhaps early life household air pollution exposure, and here again, we're looking at PM 2.5, is associated with increased risk for systolic blood pressure at age 4. So I think, if we're about trying to summarize and bring all this data together, I think what we can say is that early life household air pollution exposure, beginning prenatally, clearly affects child health. And we see that prenatal exposure influences lung function, both measurable at 1 month of life and then measurable again at 4 years of life. It appears that this poor lung function then sets the stage, perhaps, for increased risk for pneumonia in childhood, which we know is a leading killer of children under the age of 5, and perhaps may play sort of into a feedback loop of then further impairing lung function, which again, we can measure at age 4. We also see that prenatal and postnatal household air pollution impairs nearly all metrics of growth. And this is really important if we think about childhood mortality, especially with the fact that we do see a strong association with an increased risk for stunting, which again has public health relevance. And also, we see that these growth metrics then appear to be related to lung function, where again, we see that poor growth translates to increased airway resistance, again, measurable at age 4. And finally, we're starting to see some sort of signal that perhaps cardiovascular health in childhood could also be associated with early life household air pollution exposure. So again, really just the story of early life health, interrelatedness of organ system development, really just starting to set the stage for health disparities over the life course. And so, our work really focuses on household air pollution, but clearly there's many different factors at play here that influence health. And I will say, our intervention, our LPG intervention, was not able to demonstrate a significant improvement in birth weight or pneumonia over the first year of life. And I think, I don't think it's that controversial to say that, at this point, I think we can say, yes, we need an intervention that's able to reduce exposures more. Yes, we need an intervention that's able to create more of a gap between interventions, between study arms. But I do think that we need to start thinking about how we address the elephant in the room, which is poverty. Because I think until we start to think about ways to address poverty, we really will not be successful at trying to alleviate these health disparities. And, my sort of final thought on this is I think, especially in the age of COVID, where we're seeing that this is especially true, in our population that we serve here at Mount Sinai, I think that we have to remember that economic inequality and poverty is an issue, not just globally and for people living in Africa, but also for people here living with us in New York City. And so with that, I just want to thank all of the fabulous collaborators. Clearly, this is the work of many people and could not be done, especially without the collaboration of our colleagues in Ghana, who lead just a really superb research team, and who, for whom none of this work would be possible without their support and collaboration. And then, of course, important to acknowledge our funders. So thank you so much for your attention, and I'm happy to take any questions that you may have.
Great, thank you, Dr. Lee. So if you have questions or comments, please put them in the chat so we can have a discussion. Alison, do you see Sakshi's question?
I do. So yeah, so Sakshi's asking, that's a great question. I think this is something that, we're struggling with right now with all research studies, and especially in Ghana, where there really is no testing capacity. So initially in the country, they were doing testing, but at this point, they've essentially taken the view that they cannot do widespread testing, and really in the area that we're working in, they're not testing. So we, through our study, we have deployed every 3 months, we use the WHO and MSF COVID questionnaire to try to ascertain symptoms in the community. And we're also trying to get some additional funding right now to be able to do PCR swabs to test for COVID at the start of our age 7 assessment, which was slated to begin now, but has been pushed back to January. So we're trying to take, different precautions, and obviously also make sure that our staff have the proper PPE to protect themselves, because I think especially working in a cohort where testing is limited, it's difficult. But yeah, that's a great question, something we've been grappling with.
Has anyone compared carboxyhemoglobin in mothers and newborns, or looked at less than 2.5 micron particles in placentas?
Yeah, so the placenta piece, so yes, people have looked at carboxyhemoglobin, and there was an effort a number of years ago to try to use that as a biomarker of exposure, but those didn't really pan out. In terms of placenta, I mean, that data is really interesting. So some of you may be aware, but essentially there's data now that came out of the Environment cohort in Europe, which essentially found that mothers, when they looked at placental samples, that they found PM2.5 in placental samples across essentially every single range of maternal exposure. So suggesting that even at very low levels of exposure, PM2.5 is able to be absorbed into the bloodstream, right, and reach the placenta. So that's, we've definitely thought of that. Can that be used as a biomarker? Can that be used to sort of look at the impact, right? We know that the placenta is very important in sort of driving fetal growth. So we have placental samples for our entire cohort, and it's something that we're definitely in discussions to try to find some funding to do that, because I think that would be really, really interesting and a way to kind of push the field forward.
Alison has a couple questions in
Yeah.
the chat.
So
Rachel.
Rachel is asking sufficient variation to assess what may help with recovery of growth parameters. Yeah, so we do see variation in postnatal exposures. As I showed in the growth trajectory, we don't really see growth recovery. I mean, maybe we see a little bit of a change in slope between 12 months to, let's say, 48 months, but we don't see a trajectory that has like a rapid rate of improvement, similar to, if you remember back to the slide with the large cohort of FEV1 trajectories, where you do see there was one trajectory that had an improvement. We don't see that. That could just be limited by sample size. So for our current work, we're following 700 mother-infant pairs or mother-child pairs. So it may just be that our sample size is not large enough to give us, multiple different subphenotypes. But it's a good question, and something that we should definitely look more into. Comparative data on PM2.5 in New York, especially in congested areas. Yeah, so the other piece of my work, my K23, and then actually also my current R01, is working within Dr. Rosalind Wright's cohort, which is a birth cohort here in New York City, where we're trying to understand the influence of prenatal and early life ambient air pollution, specifically PM2.5, on these same metrics. So my K is actually measuring lung function at age 4. And so we are in the process of analyzing those data, but we don't have that specifically yet. But if you look at the work, published by her group, and also, Rachel, you're on the call, published by your group as well. I mean, clearly there's a lot of data out there suggesting that, prenatal and early childhood PM2.5 exposures influence child health over the life course.
Is there any difference chemically in food cooked on wood stoves versus gas stoves?
Yeah, I mean, I think so. The exposure piece, I think we have a lot left to explore there. So as I said, we're measuring carbon monoxide and PM2.5. We have urine banked, so potentially we could look in the urine for other markers like PAHs and other markers of exposure there. We have filters banked for all of our PM 2.5 exposure assessments. So I think, there still is a lot that we could potentially do with the exposure piece and try to understand how those differences may play a role in health. Obviously, a lot of those are sort of expensive analyses and we're limited by funding. But I think that's a great point that that some of those differences as well and sort of what you eat can play a role, especially if you want to think about childhood growth.
Francine allowed people to unmute if you have a question that you'd like to ask. Okay, well, if there's no other questions, I really want to thank Dr. Lee for a really terrific topic today and great work. Really impressive, Alison. So thank you very much for this. And thanks everyone for joining us today. We'll see you all next week. Have a good one.
Thank you so much.
Thanks, Alison. Congratulations.
Thank you.